Good afternoon, ladies and gentlemen. Our webinar is going to begin. I'm Steve Love, President, CEO of the Dallas-Fort Worth Hospital Council. We certainly want to thank you for participating today. This is an educational webinar hosted in coordination with Forvis Mazars, who is an associate member of the council. We've worked with Forvis Mazars for a number of years, and they're valued friends of the hospital council. Today's topic, rising to the challenge, key strategies to drive higher margins. What a great topic, one we have to look at. We know the one big beautiful bill. We know there's still debate on the enhanced premium tax credits. So this is going to be a great discussion. Two national experts that have decades of healthcare experience. They're going to discuss strategies and suggestions to reduce cost and to improve efficiency in the market. Our speakers today are Peter Stille, Managing Director of Healthcare Performance Improvement for Forvis Mazars, and Jeff Bond, Employee Benefits Subject Matter Expert. And we're looking forward to their presentation. Before we begin, though, please note if you have questions, please type them into the question box. At the end of the presentation, we're going to answer those questions. So be thinking of them and make sure and put them in the question box. With that, it's my pleasure to turn this over to Peter.
Thank you, Stephen, and good afternoon, everyone. It's a pleasure to be here. This is my second time speaking, so appreciate the invite back. We're excited to share with you some great content with an organization whose relationship we value here at Forvis Mazars. I sit in the healthcare consulting division for the firm, and I can tell you that the Texas market is our largest market. And we spend a lot of time and focus there trying to help clients move forward. And from my perspective, it's a non-labor focus, it's a margin focus. And we'll have a lot of content to share here, both for the community healthcare organization as well as rural and larger. And so I do ask you to listen to those nuggets that you can pull away and bring home to explore tomorrow. And if there is additional detail that you want to help take some of the things forward in your organization, my contact information will be listed at the end. So today we wanted to do a brief state of the industry and like why cost reduction is something still relevant. And what we're trying to answer is what is next. And this types of forums that we're participating today in this webinar are really a key part of this, to keep your antenna up, keep tuned into what is happening in the industry, what are some additional ideas to be tracking and keep top of mind and explore further. So really appreciate this time to talk with this group today. I do want to turn it then to cost management. I've done this for 33 years, and we've seen different iterations of this. It's always, we need more money and more savings. But we've seen a different shift in the recent years that we'll go over to kind of show you how this is changing, how strategies are changing, how opportunities are changing as organizations manage their costs in different ways. And then finally get into some of those things that we're seeing that are working, and they're working after years of pounding on this and making investments and improving. And we broke it into 4 buckets: emerging solutions in the market, contracting in difficult markets, in this case, an inflationary market, expanding existing efficiency programs, and then new approaches to old solutions. And then finally go to guidance and takeaways. So with that, a brief introduction of myself. I'll also ask my co-president to introduce himself. I've been doing this work since 1992, started with Anderson. Back in the day, I like to say it was 1 or 2 ply toilet paper and metal or wooden crutches. And though it was valuable stuff, but we had a turnaround practice, and there's really a maturity of the supply chain coming in where we applied more of a sourcing strategic approach to reducing these costs, and really began to invest in a new type of way of approaching on labor costs. I've enjoyed being able to help clients along the way, and have been challenged enough to not be bored after 35 years of doing this. With me today is Jeff Bond, our subject matter expert in employee benefits. Jeff, if you would.
Thanks, Pete. My name's Jeff Bond, and I was part of the team that started a provider-owned health plan. I worked for Cox Health in Springfield, Missouri, about a 13,000 employee health system now. And we started the plan back in the mid 90s. And by the time I became CEO in about 2001, we had $21 million in negative retained earnings. And it was one of those situations when I was named CEO that I actually had people saying, I would not want to be in your shoes, because, the plan actually was failing on a number of, areas. And my job was to fix that. And so many of the strategies we're going to talk about today are things that I used and can still be used today. And we are definitely using in the Forvis Mazars practice to help health systems reduce cost on their employee benefits. And so I'm very glad to be a part of the presentation today. And hopefully you've, as Pete said, take some nuggets away from this that you can put into practice.
Thanks, Jeff. And employee benefits is one of the areas we'll spend a good amount of time, largely because it's the largest savings area that we're working on right now. It's beat out traditional areas of GPO and PPI. Before we get into that, just to lay the groundwork a little bit about what we're seeing in the market. Forvis did a survey called Mindsets of key healthcare executives, CEO, COOs, CFOs, and I found the results interesting. They're similar to the previous year, where margins were continuing to decline. But in the 12 months leading up to this survey, they're increasing. But the executives still ranked margin improvement as one of their top concerns. And I think that goes to show just the experience of the executive, knowing that there's another shoe that typically is going to drop. And wouldn't you know it, as we track, and I'm sure many of you track, the Coffin Health Flash report. 2 months ago, it saw the first decline after several months of increases on the operating margins, and so they're starting to see the impacts of tariffs and other pressures there. Most of the majority of the challenges that are seen are on the cost side. There's a lot of effort on revenue cycle. There's still opportunities there. There's still concerns. And revenue cycle, I think, is one or two of that list. But the rest of that list really is how do we manage our costs, which are right now increasing and continue to increase at an alarming rate. 35% of organizations, because of these pressures, have missed a majority of their strategic goals. And if we're going to be working harder to find some solutions, it better be easy, because we're tired. And if it's not going to be the people in the four walls of the organization, we're going to have to make good choices of partners to work with to help us move the organization forward. And so I chose, again, this source is for Kaufman Hall, the costs side of the business. And I right-size this for volume. And what I take away from this is similar to the conclusions that they publish, as well as just, I think, interesting insights to where things are going right now in healthcare. Right now, your total expenses exceed the increase in total net revenues. You're also seeing that the pressure from the payers and both commercial and government are continuing to not keep up with the gross revenues. But other interesting takeaway here is that you don't see labor But you see everything else besides labor above total expenses. Labor is actually lower in year-over-year price increases than these other categories shown here. One, supplies, key part of non-labor, 23% of most organizations in acute healthcare's expense structure. Drugs, and you can see drugs is at the highest. This will contribute a lot to the employee benefits that you're managing as well. Purchased services, which is harder to get your arms around because that data is manual in nature, is not captured well on a PO or into a cost accounting system. There are big strides being made there and good strides, but purchase services is increasing again at a higher rate than others. And these would be things like your contract labor, IT would go in here, even broadly defined like utilities and maintenance. And then I wanted to highlight bad debt and charity. This is increasing higher than the other categories, and I think it's alarming because not only is that just straight off the bottom line hits, but it's going to get worse with OVA. We've all seen what's coming down, increase in self-pay population, more use of the ER. So you know, these year-over-year expense increases that we see them being higher if we look at this a year later. So the pressures are not going to get easier. We're not going to expect that the government, Congress is going to bail us out with, or the managed care is going to give us higher rates all of a sudden. If we negotiate, then we can, but reimbursement gains are just tough to get. Volume gains are tough to get, but the cost reductions do hit the bottom line. So one of the reasons I think this discussion is important is that there has been a lot of effort into cost management, and so much more than back when I started in the 90s at Anderson. And what I've seen the past couple of years, and I use 2022 as the last year in what I call the prior, and then we looked at 23, but really more 24, 25, because a lot of those initiatives that we were working on didn't start until then. A shift in focus where before it was a lot on sourcing, and less on utilization, and then I'll just categorize it as other. But really, we've seen a dramatic increase in both utilization, which is harder to do. It's harder to hold on to. The tracking of that and the controls of that are much more important. That's why I think there's been more focus on sourcing and vendor management up until this point, and spend analytics and the like. And then other, you start to see some new solutions coming out that really don't fit into either of the categories. I'll go into examples of that later. We also see a shift in categories where a lot of focus had been on supplies, and that was the main contributor of savings. Now we see less of that, still the majority, but benefits at 40% or maybe 30% of supplies. That savings has really increased over the past several years that we've seen. There's been an increased focus in that category nationally as well as in our practice. And then the same with purchase services and the efforts to continue to try to get your arms around that and invest in analytics and give you visibility to control and manage those expenses has increased that impact as well. And then again, you see some things here under other. I'll give a few examples now. One, patient assistance programs, and you may have heard of some new solutions coming out. One is Cinnamon, to help get your arms around a win-win-win to try to give your indigent patients or even your commercial payers relief on their co-payments or foundations. And there are some data rebate programs out there in pharmacy and other areas that can really add up. I had one client in the Southeast that had $3 million in data rebates just from what they were doing in pharmacy. That program didn't exist 3 or 4 years ago. So the industry is trying to come up with ways to provide value, and just trying to keep on top of that is part of the game there. So I wanted to go through these 4, and we wanted to do it in a case use example format to give you just some tangibility and specifics about what we see here. This is a client that will dive into $1 billion in net revenues in California, a few thousand employees. And we wanted to start talking about not just PBM, but to start with PBM. We put employee benefits here as an emerging solution because it is gaining traction in the market. A few of these solutions out there, but as you'll see in some of these areas, these solutions have been around. There has just been some headwinds to gain traction for existing solutions that have been around, for decades. Really, the existing establishment either is distrustful or has disincentives or just doesn't understand what the value of taking a risk on someone that's not a big three PBM. And we'll start with PBM because it is the largest savings, not the largest expense. We'll get that in a second in employee benefits. And high level for everyone who's not a benefits manager in their career and kind of wonders what this PBM thing is we're talking about. And these are really organizations like an Optum or ESI or Caremark that helps establish the formularies for your members, your employee patients to receive medications or not, and which medications they should be, and et cetera. Well, there's been a lot of focus on this, and last year, Wall Street Journal published a study that the FTC did, and it was commissioned, and their conclusion was, the U.S. government said that the large PBMs would control 80% of scripts in the market, increase drug costs. Their model has been more effective for them, and their margins that has been actually reducing the cost of care in America. There's a lot of reasons for that we'll get into, but one of the nice things that we're seeing is that there's legislation addressing some of the problematic features of those traditional models. And there is what I think of as a flood of new entrants in the past 3 to 5 years of PBMs that are trying to position it differently. Instead of having a focus on high brand, they're having a focus on high clinical resources and providing that consultant directly to the doctors and to your patients and to the pharmacist. And they're not bound by a formulary that has a rebate attached to it that they might be making margin on. They're interested in the lowest cost option. Is it a biosimilar? Is it a generic? There is a strategy out there called own use, and that is another way to purchase at a lower cost. There are innovations to get to 340B pricing and use GPO pricing as well. A lot of those are not pursued by the established PBMs. And then finally, and this is something that pretty common at the state and federal level, you see is really making sure that the fees are transparent. I think that there are, what I've seen, 38 different revenue stream potentials for a PBM. A lot of those are hidden. Really having a one fee upfront, disclose it, is really the ask, and a lot of what people think is the important part of trying to get your arms around what you're paying and what's available to you in the market. They're also trying to avoid conflicts of interest, like self-referring to your own specialty pharmacy, defining specialty pharmacy versus brand in the ways that you want, et cetera. So I'm going to cover a little bit more here, but Jeff, is there anything else you'd like to add?
Yes, I would just say that, as I mentioned when I was introducing myself, I inherited a badly broken health plan that had almost $22 million in negative retained earnings. And so when I set out to address that, what I did is I identified 3 levers that I wanted to pull as far as repairing the finances of the company. And the first one was things that I felt like I had control over. what actions could I take that I knew I could, reduce cost in the health plan. The second one was things that I would like to control. I wasn't sure I could, and identify those and put specific action plans in place once those were identified. And the third bucket was things that, frankly, there's a lot of money spent on some of this that I felt like would never be controlled. And the reason I bring it up is because some of the things we're going to talk about in the biggest savings for the health plan that I ran that had the biggest ROI was the PBM. That is an expense that can be controlled. It's a risk that as risk managers in your respective health systems, you have to look at this kind of like the same way I did. It's a risk that can be managed and controlled. And we're going to talk about some of the ways that we did that and some of the results that, that we achieved.
Thank you, Jeff. And so we'll get into some details here, but to transition employee benefits, average 8.4% of OpEx. You can see what the total health costs are per member per month is how it's measured. Pharmacy costs are less than a third of that, but they, in terms of savings, typically make up, over 50, 60, 70% of the total savings we get in employee benefits. Total savings per employee per year that's averaged is $892. The PBM savings is 28% on average with wide variation. And the last thing I wanted to point out here is that there is a lack of accountability here. You got VPs of HR without finance training, and in budgets that are really predicting where the market's going, not predicting how well you can manage these costs. We see some value in putting cost on an employee benefits committee as a part of its charter, making sure that finance and operations are involved, and making sure that when, as a few of our clients saw the past year, savings went up 25%, one went up 40%. The PBM said, we saved you a lot of money on the rebates. We need to talk about the drivers of those costs and how do we get our arms around them. And so that's where we want to show you the results here. And I just want you to see that really we have a trend line at the top of where things have been going from 23 to 25. And what that means, going forward the next 3 years. And then we got in orange a bid from the incumbent, and we got 3 other bids, each what we call lowest net cost PBMs. One of the differences you see here is that they came to the table with clinical programs that they thought that they could implement. They also came in with some different strategies about how to manage costs for patient assistance. But really bringing in innovative things like own use, which if anyone hasn't heard of that and wants to know more, you can reach out to me or look it up. But it's not a well-known way to access drugs at a low cost, getting towards 340B pricing. But what we saw was that the net PBMs were trending at a much different in their client portfolio than the portfolio of the incumbent. And we asked the client how they want us to manage that and model it, and this is what we have. One reason we feel good about this is they're all kind of ending up in the same place, which is in 2028 saving 30%. But the line in red is guaranteed, so we do have some comfort that these numbers are based reality and that there is some enforceability. And even though the green will not guarantee those savings, they will hold themselves accountable to doing reporting. I have one other comment here, but Jeff, is there anything you wanted to add to this example of the market results for that California client? I think you're on mute, Jeff.
I apologize. I would echo what Pete just said. Unfortunately, the RFP process that is used in the PBM industry doesn't incorporate trend in the repricing analysis. And, this is something that I kind of fell victim to when I was trying to manage the PBM cost at Cox Health Plans, the company that I ran, because we had done this work just like I'm sure many of you do. You get a broker. Of course, I didn't use brokers at this time. Actually, I take that back. At the time, we were using a consultant. I fired the consultant, and I traveled around the country looking for a PBM that I felt like could get me off of this kind of hamster wheel of never-ending cost increases. And so I ended up with a company called Catalyst RX that was truly a lowest net cost pharmacy benefit manager. And we were able to, impact trend in the first year of doing business with those guys. My trend went from over 5% to minus 1.5%. And so I think this is the power of lowest net cost. And you see it here in the slide that Pete has up. And again, unfortunately, in the RFP process, this never seems to make its way into the analytics that you receive when you're trying to determine which direction you want to go. And so I would strongly encourage everybody to really understand how trend impacts your future cost, and then try to align that with a PBM that has aligned incentives with your organization, because most of the big three, in my opinion, don't. They're set up to really be profit generators for themselves, and then they have a marketing process that really focuses on rebates and really ignores trend. So I think that's what I would say about it.
Yeah, and I think a good example of that is when California passed SB 41, asking for less hidden fees and fiduciary responsibilities. The next day, we received an increase of $500,000 in fees. The last point I want to make here is that you'll never see this in a at least we haven't, in a PBM market result with your broker. But we do think it's something you should ask for. In this case, the broker was in a coalition with the big three, and when they presented the results, it was that orange line was the best solution because they did not trend versus what the historical trend has been. They ignored clinical savings. They ignored some other things as well. So two other quick examples here. Plan design. As healthcare organizations, we have the opportunity to serve our members at a lower cost, obviously. But the capture rate varies. So we worked with an organization in Kentucky, right around 100 beds, saw that their utilization was below average, looked at different options, performed an analysis that showed that by reducing copays and increasing that spread between in-network and out-of-network, domestic claims could be shifted of 7% of the total claims to the organization, performed at the margin variable cost and net savings $562,000. One of the things that I was happy with was that the client agreed to do this with an actuary, and it really took away a lot of the discomfort about, is this truly going to happen? The second example is working with case management. And, both of these are in an attempt to try to tackle that other 67% of the expenses in medical. And when you talk about case management, this is everything else medical. And what we've seen and what we saw at this client was they were paying probably twice as much fees as they really understood. The lack of reporting and the analysis that was presented by them and by the broker just really did not capture a lot of fees that were being charged on a claim that they were unaware of. There are opportunities out there. Unions make good use of this with all of their focus on trying to reduce costs for their members, to employ professional case managers. The TPAs either don't have this function or are not incentivized to maximize on it. And when we've seen that outsourced, we've seen return on investment of 8 to 1 on their fees. And some organizations will guarantee put some fees at risk for that. And in this case of this client, the savings were estimated at $1 million a year. And it came both from managing some of the complex claims like oncology and cardiology, as well as some negotiated safety health. Jeff, do you want to add anything?
Yeah, I would, Pete. I'd say on the first issue with plan design, bringing the actuary in on this health system's employee benefit plan structure was done because we were working with a big brokerage firm, one of the big brokers, and when it came time to talk about this idea of trying to drive more utilization into the domestic setting, the owned health system, and it was quite a bit below 50%. The broker was, I felt like, kind of just grabbing things out of the air. So, we suggested to the client, hey, let's bring an actuary in. They have very sophisticated models where they can measure the X change in benefit design will equal Y result in utilization. They're very good at that. These were people I used in the health plan that I ran. And kind of lo and behold, we were able to identify some, I think, plan design changes that really wouldn't have come up without the inclusion of the actuary. And I would just wager that most of the health systems represented in this meeting probably don't use actuaries in their analysis, but I think there's some value there. And I do think it helps you, identify changes in a more scientific way. It costs a little bit of money, but the ROI, I think, is pretty substantial.
Yeah.
Secondly,
6 to 1 ROI there, Jeff. Yeah.
Yeah. And then on the case management side, one of the levers that I identified in repairing the finances of the health plan that I ran was fixed costs. And we were spending about 20% of our fixed costs in our medical management department. And we had a bunch of policies and procedures. And I went to those folks and I said, well, we're spending all this money. Show me the results of your work. And, they couldn't identify any, savings, any ROI, here and there, but not in a way that you would as, when you're running your respective organizations. So honestly, I made a decision to outsource this work to an organization that we've used a couple of times in the Forvis Mazars work. And they're very rigorous in terms of managing cases and identifying savings. And I think it's imperative. And I think it's honestly an area that kind of slips below the radar and many times because, for example, in this health system in Kentucky, there were the health system was spending hundreds of thousands of dollars with their TPA on medical management. And, we asked the people that ran the TPA, show us some savings reports. Well, their answer was, well, we don't track savings. And so I just think you have to do it. There's a lot of time, money, and effort spent on this. I think you have to identify where you spend the money. I think you have to make sure the work's being done correctly and that you're getting reporting that lets you have a comfort level that these large claims are getting managed. So I think that both of these areas, I think, deserve a little more rigor than in many cases they get. And so these are two strategies that we've employed at Forvis to kind of help, produce the best outcome possible.
Yeah. Average about 5%. And so to close this area out, we would recommend organizations go to the benefits committee or their leaders in finance and in HR and ask them, to articulate and push their partners for return on investment. Look at the plan design and ask if we've got research into that domestic out of network proportion, and that the PBM, what they call the RxPM that's being tracked. Have they researched other alternative strategies to try to reduce that by 10, 20, 30%? So moving on to the last three, these are a little more compact in discussion. Contracting in an inflationary market. First, I want to give the guidance to lock in early in the cycle when you do see that inflation is on the horizon. And when you do that, you've got the opportunity to update the rules of the game. And not only will you have a lower price to lock into, but you can avoid having surprise surcharges and additional fees, even having a term in there saying that no other fees are allowed for in this arrangement. It is good enough protection. Will it hold in every case? No. Eventually you need the products and supply and demand need to happen, but this is a strategy we use when gas prices go up, when these tariffs come through, etc. And then when they do come through, I just want to mention that a 50% increase in paper that I saw 20 years ago actually only translated into increase in cost of like 20. Because the majority of the landed costs that you pay for includes shipping and includes administrative fees, marketing, and other things. You have to look at that cost of goods sold and even break it up after that, because of the cost of goods sold, not everything is paper and pulp in my example there. And then the last thing we want to talk about is really these four graphs in front of us, which is you can still reduce costs in an inflationary market. With an organization that has increases themselves. They are using AI, by the way, and they're doing efficiency programs to help offset things. And so that needs to be researched and understood. But teaming up and collaborating, aligning incentives is really the other strategy that we use here. The example I wanted to give is at orthopedic implants, where we are in Southeast Kansas at a small rural hospital with a decent sized orthopedics program, but not large. It was split as well to two different manufacturers, but we were still able to be successful. And we did it by approaching them and talking about the need to align with them to simplify how we did business, as well as to drive better decisions for patient demand matching. And so I'm going to point you to the blue bar there. The weighted average previously was about $4,200 a knee, and it went down to under $3,750. And they lost $0 in margin when they did this, and they did that because you can see that there's different types of knees that they had before, and through this that high demand knee that include a revision component that's at $7,000 and almost twice the average. That frequency of usage went down 75%. That rep and that doctor talked a lot more about making sure that was the right fit for the right patient at the right time. So savings were 10%. But again, the margins for the manufacturer remained the same. And in this arrangement, they had the opportunity to increase their margins, because they have experience in other categories, such as other supplies used in that total knee. Antibiotic bone cement, studies vary about whether that's got a good clinical outcome. The difference in cost is it's 80% less to use plain bone cement. This is a market in the industry. People are kind of seeing this that vendor got on board and started to make recommendations about managing that as well. And then finally, on the outpatient side, and how this works is we set a goal of 5% savings every year for them to recommend to the clients. And if they're able to get above 3% implemented, then they get a bonus. If they don't hit that 5, they get a penalty. And one of the things that we started with that we knew was an issue was that inpatient or outpatient needs as a percentage of total needs were going up. And for the first time, I think it was last year, you saw complications with total needs going up. So there's a lot of discussion clinically about, has that been an overcorrection? And what we saw was that the default was to the outpatient side. If you didn't have the documentation, that's where it was going. But in a few cases, it really should have been. Maybe like another 10% should have been inpatient more appropriately. There would have been a readmission that was missed, and et cetera. Plus, there would have been more reimbursement. Well, the rep had a relationship with the clinic where he was able to get it to joint camp, which was really the problem, is that communication between the clinic and the joint camp to make sure that documentation is there for that doc to make the decision. And then finally, having different discussions about what that investment in the robot means, and even leading to some discussions about not replacing the robot after the lease, which were non-existent conversations prior. The third example is really expanding efficiency programs. So if we're not negotiating with suppliers, we're negotiating with ourselves. And this is really what we call utilization. You've got sourcing, you've got utilization, you've got other expenses. On the utilization side, this is again the higher hanging fruit of the tree, higher to lower return on investment to get at, harder to hold on to. You get change a lot of more people's behaviors internally. But we see success with this and really expand the value analysis approach into clinical variance, into surgery. And what you see here are the average costs for a handful of doctors for a standard lap chole procedure. Didn't come through the ER, didn't have a robot. And so what organizations can do is get that data, cost report, cost accounting data, or even revenue charge information, validate it, line it up by doctor, see what's driving these variances that you see in these different bars, and have a conversation with them along with the outcome data. Are you getting the outcomes that you want from this? Why are you using this closure device or this pharmaceutical or this lab test and imaging test that the other doc is not? Would you be interested in trialing this and see how that went for your patients? And what we've seen was not a correction of the variance, but half of the variance, typically within 3 months, is corrected. I would say that 75% of the time the doctor says they won't change that first meeting, and half the time that they do on their own, either the way that we would have hoped or in a different way. And the key here is just following up and tracking this and bringing this into the OR management monthly meetings so you can create some momentum. The other area that I wanted to share with you is waste workouts. This 30, 60, 90-day approach that a lot of us have heard of and maybe have been active in. We've seen an expansion of these efforts, a restarting of these efforts, and where someone might have a Lean Six Sigma effort. This would be more like the rapid events. And a client that we're working with right now in Indiana has got a goal of $10 million. They're only about a $300 million community health organization, hospital organization. And they ended up having $17 million implemented through this program. They have another $8 million in progress, and it's great because by the time they started this program, it turned out that they needed to reduce their cost by $30 million. So this has been very important. And I lay out for you how this works by department. You can see it's a house-wide effort. And there's momentum around this. There's some celebration around this. There's some executive sponsorship here. And this gets competitive. When I first showed this list to the organization, they got very upset because obviously surgery is a bigger area, and IT and supplies, so they can get more. Finance can get revenue, so we turn it into percentages, and then every month at the manager meeting we gave out gourmet cupcakes. And the winners at the 30 days, 60 days, and 90 days got a party for their department. So this is something that, is baked into the DNA of a lot of organizations. Kaiser does this as a religion. And is something that when I've seen this in the Northwest for one of the largest IDNs in the country, I had done 2 projects for them on a non-labor side. They'd done 2 others in 5 years. Then they did a 30, 60, 90-day workout, and they said that was the best project that they had done because they had listened to the end users. They brought more ideas to the table, and they felt like they owned it, and they were improving their jobs along the way. So our last area is 2 case studies, case use, new approaches to existing solutions. On the left here is contingent labor. And what we're seeing is a difference in having a prime vendor to having a vendor neutral partner where they collaborate with you not only to drive lower rates, but provide you information and transparency. Also partnering with you so you can make use of your internal agency when it's available, helping staff a nursing staffing office for you to drive this. In that office, integrating, if you want, workforce productivity software so you can have controls or at least reporting about when contract labor is used, even though it was not meeting that ratio need or it was. And helping organizations and it used to be large organizations and now it's smaller organizations set up an employee of record, a private label temp nursing agency where you can then control the expense on a shoestring overhead budget. You can take advantage of some tax issues on that stipend and drive down 10% costs just by doing it that way for your long-term contract labor. This area is a lot of different ways guaranteed to be 10%. And you can find a lot of case studies out there that are showing 30 and 40% of this category recently. And then finally, GPOs. This is one of the areas that we save a lot of money in and is really just not bid enough. When it is bid, there is not enough investment in trying to make sure that the GPO comes to the table with a creative solution, maybe different than they've done in the past. And right now we're seeing a shift towards determining who your regional GPO is that they should partner with at the national level, maybe using 2, maybe using Cleveland Clinic for the PPI portion and Partners Health for the other. And that needs to happen before the bids goes out. So we do an RFI process to really shake that out and see who we should be bidding to. And when we send in information, it's just about supplies and pharmacy. It's about capital. It's about purchase services. It's about software, and even value-added services like consulting. And then those decisions are based on the total value that is available through this important partner, and that value that's budgetable. It doesn't need to be guaranteed, but there is some additional movement in the market that we're seeing where they are taking some risk, going on contingency. Vizient just bought a consulting firm to really beef up what they can offer in the market. Premier is going private. One of the reasons we think that they've gone private is to be able to offer more to the market in terms of flexible arrangements that would include being able to articulate a business case and a savings proposition that has risk to it that the market would typically frown on. And so that's currently in place. And from that perspective, the same organization for 100 beds, we just got the bids back last month. $4.3 million was what was guaranteed by one national GPO. And then another gave 4.2, and about 2.3 of that is 100% guaranteed. So some good dollars are still out there. But this is, again, a lot about aligning incentives. And I'll skip to the bottom here for a quick second because it's on my mind. Aligning incentives is important here, and making sure that your GPO partners got that is important. Texas has a regional GPO that is very good at setting that up, and being able to be incentivized and be aligned with its members to take those risks. And if you want more information about that, let me know. We're vendor neutral, but I do think in this session it's worth pointing out that you've got a different model and solution in your backyard there when it comes to aligned incentives with your GPO and the value-added services that they can provide. So the takeaways are margin pressures are increasing, and they'll continue to. It's key, as always, set a goal. And set a goal for what you need, and then increase that because historically it's shown us that it's not going to be enough by the time you get there. And then invest time into exploring new solutions that change the status quo. That includes emerging solutions that may or may not have legs, that requires some vetting out, that your trusted partners may not be comfortable with, or be even skilled enough to do an evaluation. You might need to take a different perspective on it. New collaborations, new efficiency efforts, and new strategies in old areas. So that is what we have for you today. I would like to wrap up just by saying that it's interesting that we're seeing a lot of different things today, but still on average 2%. Even for sophisticated organizations, it's 1% savings on total OpEx, with very, very meaningful return on investments. And so I encourage you all to, continue to pound on your cost structures and fight the good fight. And if you've got any additional details or questions, or even copies of this presentation you'd like, please feel free to reach out to me directly. You've got my contact information here. And with that, I will pause and see if there's any question.
Yeah, thank you, Peter. And also thank you, Jeff. If you have questions, please put them in the question box, the Q&A box. And Peter, while we're waiting on that, you gave some good advice. When you do one of these initiatives, what is kind of the time frame you've seen to get this done?
Yeah, and not every situation needs an outside consultant, but I do think that picking the right partner can pay for itself. And a lot of these solutions are sophisticated enough, especially at this point when organizations have pounded on this, that these are more complex solutions. If you did it with an outside partner, it would take them a few weeks to get their arms around this, by getting data and talking with folks and seeing what could fit in their organization. We typically do that over a 4 to 8 week period. And then that implementation, we think about it as 6 months is kind of the easy stuff, and things might lag after that, Steve. If you got a conversion for a GPO, for example, that might be more of a 9 to 12 month time frame. And we're starting to stay around to continue to measure this and set up KPIs to track this after that 6 month period, as well as be around for those contracts that have a contract expiration date that's more than that 6 month time. But I would say the vast majority you can get done in 6 weeks. In one area, you can start to finish once you get going in 12-week time frame is our typical rule of thumb.
Right. A lot of the people on this webinar are down in the trenches. So when you think in terms of this, I'm sure their question is, how heavy a lift is it for this kind of project? And I know that's going to vary hospital to hospital.
Yeah. Yeah. And area to area. And I think it's a great question. And what I can say is that lift, if it's done right, will always pay off. If you do it internally, I think it's 12 hours a week to be able to get it done in a 4 to 6 month time frame. if you sought a partner, I think that you would be able to reduce that time by about 80%, and they would be spending that time for you. When I do these projects for regional healthcare organizations, we typically budget a few hundred hours to do it in a week. And for the client, we try to limit that to 2 hours a week on average.
Great. You know, you went through some great discussions looking at savings, looking at ROI, and on the surface, these savings would almost seem intuitive. Why do you think that the focus on these kind of savings aren't part of the normal duties, say, of a department head or a department leader? You have any thoughts on that?
Yeah, I think it's again a great question, and I think that's why continuous improvement works at the best organizations out there. And GE built to last. I think that change and continuous improvement is a process, not an event. I don't think you're ever done. I also think that management of a hospital is complex, and the supply chain is, I think, probably the most complex industry in the world to manage. And so to be able to get your arms around that, I think the industry's had the budget to be able to invest in it, to get it to a point where there's less of these opportunities available to them. And then I liken it to our physicians. There's only so much you can ask of one director of supply chain. There is a lot for them to do. They can't be experts of everything. And so when I talk to mid-sized organizations, I tell them that they should seek out subject matter experts to turn to when they do have to do a biomed RFP. That might be their GPO, that might be someone else. For large organizations, they can insource a lot of that talent. So I just think that it's a fact that there's not enough budget to go around to get the bandwidth to invest in the skills to be able to do this on your own. And even if you did, there'd still be some incremental opportunity. And I think about performance excellence programs that have been cut for budgetary reasons or just lack of productivity over the years. Kind of keep how do you it's just a hard thing to do, and you'd really have to invest in it the way that a national consultancy would.
You gave some good advice, and one of the things I really like that you touched on is even when you complete the project, you've got to measure the outcomes to see what are you achieving, especially not only on ROI, but on the objectives you set out to do. So what is your advice to organizations as they look at potential opportunities that are available to them? What would you say in your mind are the keys to success?
Yeah, I love this question because we do a transition document. It'd be great if we would agree to it, and then no one would do anything about it afterwards. Now, a lot of these savings stuck, but natural attrition, 10% one year, 15 another. So we started sticking around and requiring it, where we do it the first quarter to measure, do it together the second, hand it off the third. And the key to me for that sustainability is to collaborate with your suppliers and hold them accountable. You've got KPIs you can track internally, and you've got levels of detail you can get to. But to measure a savings on a contract, that one client I talked about, they had 376 different initiatives that they were tracking savings on. And they talked about this just yesterday, actually. And I told them that they needed to build into their contracts. And something we do as a methodology is to make the vendors that we're working with, especially the strategic ones, to self-report on compliance, both the price that they offered as well as to the savings that they've offered. So Then you take that, you vet that, make sure it's real, and then upload that into your EHR, and then you use that to complement the KPIs you're already tracking. So you can get your hands around this monster. On the front end, it's really believing that there's the opportunity out there, investing the resources to go after it, being honest about the skills that you have and the skills that you can augment real time, and then and it comes down to executive sponsorship and oversight and project management accountability. Uh, I'll throw in there one last thing. We stay on the low change side, and I think the first part of our project is important to gain some momentum that way. When you start to get into change and physician preference and physician pay types of things, we handle those very carefully.
I don't see any further questions pending, but Peter and Jeff, what a great webinar. Thanks for the overview you gave us. And I wanted to repeat what Peter said. As you can see, his email is on the screen. And if you want a copy of the presentation, please email him and he'll send you a copy of this presentation. But again, we want to thank both of you. We thank Forvis Mazars for the support they give the Hospital Council. And we want to thank all the people that participated on this webinar. And at this time, we are going to conclude the webinar, and we hope everyone has a good rest of the day. Thank you.
Thank
Thank
you.
you all.